Hey guys, welcome back to my YouTube video channel. I am so excited and honored to have Dr. Steve Mautner in the house today. And he is the legend that you know that on all the social media, he one of the things that I love to Steve is that all the comment that he make is it just make me laugh and making a lot of sense. So that's the reason why I love him because he's very genuine and very honest and very smart, intelligent man when he answer those questions on any topic in whether it's a dental Facebook group or dental town. And in fact, he had more than 17,000 posts in dental town back in 5-10 years ago. With now I haven't checked it, but I'm sure there's a lot more
No,
things that
actually, I
he.
got thrown out. I got thrown out.
Oh, really?
Yeah, 6 years ago. So
I
that's
see. That the last time when you were talking with Howard Farron, right? I was just
yeah,
listening to that.
yeah.
Anyway, Steve is a powerful think tanker. He got a lot of knowledge to share, and I'm so excited. Steve, I'll let you share say something so we can start it.
Okay. No, well, so I'm as you said, I'm very involved with all the Facebook groups and in dentistry. And one of the themes that I've noticed since we came back from COVID, and inflation is getting worse and worse throughout the past months, that everyone's in a rush to drop dental insurance because they think that because the fees are so low, they won't be able to keep up with inflation, which I think is the worst possible thing you could do in this type of an environment, because with the way the economy is going, this inflation is going to lead to a recession and people's budgets are going to be squeezed. So if you're going to not accept patients with dental insurance, you're limiting yourself to either very wealthy families that have good cash flow, or people that don't have dental insurance, but they're struggling. They're a typical family of four. The median income is what, about 65,000 maybe at this time. So if they don't have dental insurance, and then the mom needs a crown, which is a typical fee is like 1,200, that's another subject. That's too high, but that's $1,200. So that's a week's pay. So if they had dental insurance, that would offset that. But no dental insurance. How are you going to expect a family of four with an income of 1,200 a week to spend 1 week's salary on a crown? I don't. That's not happening. Unless they have credit or a few savings. So that's one of the things that I've noticed recently. I think that's crazy.
Hmm.
So
it makes
unless you're in a part of the country that there's not a lot of dental insurance.
Got it.
But in a lot of areas of the country, like especially where I am, there's a lot of dental insurance. So if you don't participate, I think you're in trouble.
I see. So your encouragement is to look around and see what's going on with your area, your local area, and focus on the need of the patient, and focus on the economy, how it go, instead of just hearing from other people from other state, other region of the area, and just do what other people do. That can get us in trouble.
Right. I think so.
Yes, I agree. Yeah, that makes a lot of sense. And I understand that, you've been practicing more than 35 years by now.
Yeah, it'll be 35 years in June.
Yes, so you are a long-term experience dentist. So you have so much information that you can give and share wisdom and knowledge and experience share to the young dentists. So let's talk about things that your office you love to do at a dentist in the office. Like, what are the service that you provide, and what are the things like that in your office?
Okay, my office is it's mostly adult oriented. I see a few kids, and I do a lot of prosthetics, a lot of crowns, dentures, fixed bridges. I do a fair amount of root canals, extractions, fillings. I take a lot of emergencies, and also I have a periodontist that comes in and does implants. So we do a lot of implants, and everything is like at a discounted rate. So So not only, so I do a lot of treatments because my fees are so low. So treatment acceptance is very easy.
Okay.
And we
So
don't have much of a problem selling the dentistry because it's affordable.
I see. And you mentioned about the last conversation that you had with Harvard, where some of the dentists on Dental Town, they say stuff like, "Oh, don't do denture." Can can you talk a little bit like why is it like important for us to at least be able to do dentist, then do that? We are a general dentist, then we have to be able to do denture, right?
Yeah, dentures are easy money. I mean, you take, it's 4 appointments. That the hardest appointment is the insertion and maybe the follow-up adjustments. But, I can make a denture in like 10, 15 minutes. So if you factor in what you get paid on that for the 15 minutes total it takes to make it, that's very good money. Or you could, either have your assistant take the starting alginates, or you do it while something else is going on. Yeah, and my typical denture, I don't get a lot for dentures. Typically, I make maybe 1,500 to 2,000 for a set. But if you're doing that in 15 minutes, while you got a crown going on another room, a root canal, maybe an emergency, an exam, a filling, if you're doing that amongst all the other things you're doing, that's very good money. I could be working on 4 to 10 dentures an hour even. Most of the visits are very quick.
Right. It should be quick, and I think the one of the reason that the young generation of dentists out there, that they don't have enough experience or training, and so they are they worry about that the denture doesn't fit and they don't know how to handle it. They
Well, they
never
never
try
fit.
to.
You have to, it's a patient manager. You have to lower the
Yes.
patient's expectations.
Yeah.
And if it fits reasonably well, then it's like a positive surprise.
Exactly.
Partials usually fit pretty well, but
Mhm.
sometimes the patients they think it's too bulky or it interferes with their tongue. So you kind of have to lower their expectations. You have to say, look, this is a removable replacement for your missing teeth. This is not permanent teeth. It's going to move around. It's going to trap food. If you want something better, you're going to have to do implants. And that's
Absolutely.
it. Don't let them like bully you into thinking you did a bad job, because the dentures are really like a compromise. I don't think a dentures is a terrible procedure. So if the patient gets comfortable with it, that's like a bonus to me.
I
You
see.
know.
Yeah, I
So I
agree.
lower the expectations and I don't
Mm.
let them whine and complain too much.
Right.
I cut them off.
That's a really good way to do it. And the key thing, other thing is, like I said, they don't have enough experience how to even fabricate a good one. What to look for.
Well,
So
don't they
that's why
learn
they
that in
get in
school
trouble.
anymore? Do they learn that in school anymore?
And they learn very little. I think I've been practicing close to 20 years, but I see that, most young dentists are just really scared to the denture. They don't really know how to do it right.
Well, then I
So,
guess I would recommend just working for somebody for a while that does dentures, and
right.
see what the more experienced dentist does. But I find dentures a very good. I don't like love dentures, but it's a very good procedure to do while you're working on other things during the day. To me, you have to do dentures. I'm in South Florida with a lot of retirees.
Mhm.
I have to do dentures. There's no way if I didn't do dentures, I wouldn't have any patience.
Absolutely.
You know?
Also, well, amalgam, you talk a lot about that too. Like,
Yeah, I do amalgams.
mhm.
I'm to not do an amalgam to me is actually harmful to patients, because I always bring up this example. I have a lot of Medicare Advantage patients. They get limited dental coverage. For example, they'll cover 2 to 6 fillings a year, for example.
Mm,
So say here's a perfect example. You got an 85-year-old woman, widow, that lives only on Social Security.
mm,
She's got this 35-year-old gold acrylic bridge from 18 to 20. She's got distal buccal decay on number 18.
mm,
She's taking blood pressure medicine. She's taking anticoagulants. The decay is subgingival.
mhm.
She can't afford to do a bridge. She can't afford implants.
Right,
I don't see how you're going to get a composite to work in that
right.
situation. So you're doing amalgam under the distal buccal of number 18. You save her bridge. It's covered by her insurance. You did her a wonderful service. If you don't do amalgam, what are you going to do? You're going to stick a composite in there? That's not working.
Right,
I don't. And if you're going to make it work, you're going to take a simple procedure and turn it into a major thing. You're going to do a laser gingivectomy and isolate it and charge her what, $500 for what's basically a filling? Because the
Yeah,
patient still thinks it's a filling. They
right.
don't care if you're using laser gingivectomy and isolation techniques, and it's a filling to them.
And then it doesn't last long. And
Right.
then it doesn't last long. But with amalgam, there is like 6 different antibacterial agent in there, and it really, kill the bacteria, and it will last, right? So I
Yeah.
agree. It makes sense for that. And people who advocate like holistic dentistry, and that's the type of people that don't want to do amalgam. But it's a controversial idea, so we just throw. Reason that our conversation here is just to give outside the box thinking. So that's where the other dentists, the young dentists, have an opportunity to hear from an expert or people that done this long of many years that dentistry, and have have a better, broader common sense than just focus on the theory, but you don't lose. But you are not practical type of person, right?
Right. Like for example, a lot of the plans they don't cover a posterior composite, or they pay more. But I'm busy. A posterior composite takes more time than a class 2 amalgam. I'd rather stick a class 2 amalgam in quickly and get paid less and go on to the crown I'm working on, or the bridge, than putz around with a 14 DO posterior composite. That's that's too time consuming. I do it fairly fast, but it does take more time than the amalgam. You know? So I mean, I'm busy. I don't have. I mean, do I have time for it? Yes, but not really. I'd rather put the amalgam in quickly and make a little bit less on that and get back to the more productive things I'm doing.
I also listened to you, and you mentioned that you love doing infiltration with septocan and get things going. Can you share a little bit of your experience about that? And
basically, in my practice, I used to mostly use lidocaine 1 to 100,000.
Okay.
And occasionally carbocaine when the patient claimed they were allergic to epinephrine, or they couldn't have epinephrine, which also, that's another scam.
Right.
By the way, the epinephrine allergy thing, but that's another subject. But I had a few patients I could not get anesthetized. And then my supply guy said, well, we're going to be selling septocaine in like a week or two. And I'd read about it. So I said, okay. So I rescheduled those patients for after the septocaine became available, and it worked fantastic. So I eventually phased out the lidocaine, and I very rarely use carbocaine now, because this whole thing with giving epinephrine to some of these patients, it's ridiculous. Most of the time, the problems with the epinephrine are guys that are giving blocks. They inject into the artery, and the patient gets a rush of epinephrine, and their heart rate increases, so they get scared. But this, without epinephrine, it's useless. I very rarely use carbocaine. Only if the patient is really adamant about their health history and they're on certain meds. So basically I use the septocaine for everything. It works great.
I agree. And then you do a lot of infiltration, right? Instead of IA, you do directly there, and you start.
Yeah, I never use an IA. I use for like a lower molar, or like a lower extraction or root canal. I'll infiltrate, then I'll use a Ligajet. And that gets pretty good anesthesia.
Beautiful, because a lot of dentists, they've been trained to do IA, and they associate doing it, and they take forever. And I agree with you. I do the same thing, infiltration, septocan, get started. But this is a conversation where just let the other audience to hear it, because they don't believe that how we can do a root canal or a crown with just infiltration. But I told them it's just fine.
Well, a crown, yes, but a root canal, I'll infiltrate, and then I'll go in with the PDL injection, because I find for a root canal you need more. For root canals and extractions, you need a higher depth of anesthesia. But for a crown, you could definitely just infiltrate, except on a lower molar. I use the PDL injection for that too.
And then you said you don't do IA, even you
Never,
do.
never.
Wow.
That's that's a terrible injection. You're shoving a big needle to the back of someone's throat. It doesn't even, and plus it doesn't even work.
Right,
No
right.
wonder we
Okay.
get a bad name. We're sticking needles in the back of people's throats, then we're drilling teeth and we're hurting people. And
And
then we're getting money from them. Would you want to go to someone like that? I wouldn't.
exactly. And then the numbing gonna be like 3 or 4 hours, 3 or 4
Right,
hour after that.
right.
It's unbelievable.
Yeah, it's a bad technique, unless you're doing oral surgery where, you're going after submerged root tips, or possibly implants. But if you
Mhm.
have a PDL and the tooth is visible, infiltration with a Ligajet afterwards is a great injection, and it's quick. It's actually instant. Sometimes if I'm in a rush, I go right to it. Usually
Mhm.
I don't, because the patients will think I'm a maniac if I start working on them right after I give them the injection. But you really get instant anesthesia.
I love it. And I understand that you are the third generation of growing up in a family with dentists. Your
Yes, yes,
father,
yes.
your
My
your
grandfather.
grandfather too.
Yeah,
That's
my uncle
wonderful.
also was a dentist.
Wow.
Yeah,
And
then
then
my mother's a hygienist and my aunt was a hygienist.
do you
So,
guys talk about dentistry at home?
yeah, my dad did all the time. Yeah.
I see. Oh, it's beautiful. And I understand, Steve, you and Emily Letran have published a book. Would you tell something, can you talk a little bit about the book that you wrote with Emily?
Yeah, that was her idea. She just said, would you like to write a book together?
Hmm.
So she basically picked the topics and then she wrote her opinion on the topics. Like, for example, what do you do when you graduate dental school? And then I wrote mine.
Hmm.
I wrote my chapter on that topic, and mine is more like humorous, and it's more like sarcastic and humorous. Hers is more serious, but it's a good
Hmm.
book. It's funny
Uh-huh.
and it's
Eh,
informative also. It depends on what you're looking to get out of it.
I understand the book is for either young dentists who want to think about outside the box, or or the new technique, and the experienced dentists to learn about something outside the box. And there must be other co-author were there too, right?
Yes, Stephanie Mapp, and I think there was one other author that put in a chapter. It's
Hmm.
also funny. Like, what I wrote is humorous. It's totally sarcastic, just like what I write on Facebook. So even if you already know what you're doing, it's funny just to read. I just make fun of everything in dentistry pretty much.
Really fun because I love your comment on Facebook because every time somebody posts something, and I found it funny that most of us we're trying to be almost like faking when we comment people, but you are real, and your comment is just real, and it's so hilarious, and it's so intelligent, it's so it's just precisely that what a person need to hear, instead of like, oh great, beautiful, wonderful, this and that. But you never make those comments. It's always something that when somebody read it, people love it. So that's why
Thanks.
that's the type of person I think is more trustful than somebody like say, oh, it's wonderful, it's excellent. But you know maybe because of Facebook you don't want to say anything else, but you actually say something that is really, really, really
Yeah,
interesting to hear.
if I was a young dentist going on these groups, I would think every dentist is a multimillionaire that never made a mistake in his practice. Everything works. None of his crowns fall out, none of his root canals fail, none of his implants fail. Everything is perfect. They have millions of dollars in the bank, loving family. Everything's good. They love their job. Staff has been with them for 30 years. They never ask for a raise. Everything's great.
It is always the opposite, right? It's always the opposite.
Yeah, well, then
Like,
there are some dentists that are really helpless. They don't have any, they have some really terrible situations, like really bad. So I sympathize with that, but there's like a middle ground. Nothing is never as bad as it seems or as good as it seems. And
yeah,
life goes back and forth. Some days everything's great at the office, other days it's terrible. Just every day is different.
I agree. would you give us some tip about you know I think in your website you use the word painless dentistry.
Right.
If the person read that, do they feel that when they come they feel like, okay, this is like a painless office, or
Yeah, they
you?
really do think that. But actually, years ago, when my ex-wife was an anesthetist, so
Oh, okay.
we used to do IV sedation, and it really was painless. Now it's more like a marketing thing. I
Okay.
mean, I'm gentle. My
Hmm.
injections are very gentle. I go very slow with the injection. You know, I give it in stages if I sense that they're, if the patient's a little afraid. So, and then, once the injection kicks in, usually that it works. So I'm pretty painless. I'm as painless as you could be.
Hmm.
It's still dentistry, but
Also, I remember that on your conversation with other dentists that you said that you are really a real common sense dentist. You don't use dental terminology in your office to
no,
patient. Can you
no.
tell the audience a little bit what do you mean by that?
I just speak like a regular person. Like if they need a tooth extracted, I say, oh, that tooth has to be pulled out. I
Hmm.
can't save that. Or,
Hmm.
yeah, I do say you need a crown. Then the patient goes, well, what do you mean, a cap? I go, yeah, a cap. And then a denture. I just say you need a denture. You need an implant. I just say it very straightforward.
How
And then
about
if they
root
really don't
canal?
understand what it is,
How about a root canal?
I say you need a root canal. I just tell
Okay.
them you need a root canal. And then they say, well,
Hmm.
what is that? So, well, we have to take the nerve out of the tooth.
Hmm. Yeah, those
Basically,
are.
I speak in very plain terms, and I don't spend a lot of time on it. Like if I could sense that they're not sure, I say, well, look, if you're not sure, why don't you go home and think about it and give me a call. I don't just sit there try to convince them, or
Hmm.
or I don't overeducate them. I just give them the basics of what they need.
I see. Were you in the same year with Edward Zuckerberg and NYU?
No, no, I graduated in '87.
So he's like, oh, he graduated later than you?
No, before.
Oh, okay. I
Yeah,
see.
he's older than me.
I see. I
Yeah,
see. Yeah, NYU produced so many amazing dentists.
yeah.
Amazing dentists. So many
It
amazing
was a good
dentists.
school. It was a good school.
Hmm.
It was.
Do you have a gum specialist in your office?
Yes, yes.
I see. Do you see the advantage of doing that? Like, do you work while you are there? Is he there with you, or you are?
He's only there on 1 day a week, but he really stopped doing most of the perio. He really just does implants.
Mm,
He hates doing flap surgery and all the other things that a periodontist would do. It's basically just implants. He'll do an occasional crown lengthening or frenectomy.
mm.
He does extractions, but it's basically implants. That's what he's doing.
What if the patient would he put the implant on the patient that who need perio surgery first? How is
Most of
that?
the patients don't want perio surgery. It's very hard to sell that. I mean, if the patient really needs perio surgery and is
Hmm.
interested, I send them to a local periodontist that does that. But that's kind of like becoming phased out. Most people would rather just do implants.
Hmm. Right, but I mean, like for example, because if we put the implant on the mouth that have gum disease, would it fail?
It's possible, yeah, it's
Hmm.
possible.
Hmm.
But okay, well, let's take an example of that. Say you have someone that has moderate to advanced perio,
Hmm.
but he's losing like 7 through 10,
Mm.
right?
Yeah.
So he may just want to treat the 7 through 10 area and
Uh,
let the rest go. I mean, he'll tell them, yeah, you need, RPC or possible, more work there. But patients, they just want to do the immediate thing. And I'll tell you, they'd rather do implants than perio surgery, most patients. We haven't done a perio surgery in well over 10 years.
Really? I see.
We used to do that. When he first started to work for me, that's all he did. And and then he started doing implants, and then we saw that there was a great demand for implants, not that much for perio surgery. The few patients, I remember there were a couple of patients that never came back for the second half of it because it was so painful.
Right.
And here's an interesting thing: we have one patient. She did half the mouth with perio with the flaps. The
Yeah.
other half did nothing.
Uh-huh.
She has the teeth on both sides. She comes every 3 months for cleanings. She has fantastic hygiene. So she hasn't lost any teeth.
So, so that's exactly something that it's real life, real case scenario, and it reflects that sometimes like the theory in dentistry, sometimes it doesn't go with the theory. Like if you talk to the periodontist, they would go like, "Oh my God, what are you talking about? This and that." And then now we telling them that this is a real scenario. Patient have one surgery in one side, the other one didn't have any surgery, and it's still okay.
And also, what do you do with a patient on a limited budget that's about to lose his upper anterior teeth? Yes, and he has perio all throughout the mouth, but he just doesn't want to walk around without his front teeth. So what do?
Exactly.
You tell him, well, unless you do the flap surgery and the gingival grafts and all this stuff and do your whole mouth, I'm not going to touch your front teeth. That's ridiculous.
I
You
I
know,
I
that's
agree.
like if you went into the ER with a heart attack and the medical doctor said, well, I'm not going to save your life until you promise you stop smoking or you lose weight. Come back after you lost some weight, and then we'll do your open heart surgery.
I
That's
love
ridiculous.
I love
You
it.
treat
That
the
is so
immediate
common
problem.
sense. Common sense. I love that because the young dentist should hear those things because they just inside their mouth their brain with the way the periodontist talk in school, and they just cannot open that common sense approach. They can. They always just thinking, okay, this is the way to go, and they actually make the office manager nervous, the patient nervous, the staff nervous, and they think they are really smart guy.
Right.
but it just ruin the whole entire business.
It does, because you scare off patients. I mean, most patients just want to, they have an immediate problem that they want to take care of. They don't want to do all this stuff. Now, sometimes they do,
Mhm.
and then that's okay too.
Right.
But don't turn away a case because the patient needs other work. Do it in phases. Do their immediate complaint, and then maybe next year they'll come back for more if
I
they feel
agree.
like it.
Yeah, I agree.
You know?
I love it. uh, what else you want to talk, Stephen? You mentioned about what about PPO and HMO? Do you accept HMO?
Yeah. The HMOs are not as prevalent in my practice as they used to be, but
Mhm.
I accept them, and then
Uh-huh.
I accept PPO. But the main plans in my practice are union plans. I'm in Broward County, Florida, so I get a lot of retired New Yorkers, and a lot of them have union dental plans for retirees. Those are pretty good.
Is
And
that
then
the
I have a lot
PPO?
of yeah, they're like, well, they're PPOs, but you have to be on their list. And
Okay,
they don't have any out of network benefits. So they have to come to the dentist that accepts the plan.
I
And then
got
I
it.
take a lot of Medicare Advantage,
Mhm.
which this is like a relatively new thing. Medicare has the
Mm.
traditional Medicare, then they have Medicare Advantage where they go with the Medicare patients go with a private health insurance
Mm.
company. And to get the patients to sign up, these private health insurers offer dental benefits. And they've been getting better and better every year. Like some of them now even cover 2 or 3 implants a year.
Wow.
So a lot of these guys that talk about dental insurance, they're very misinformed, because all they think the whole dental insurance market is Delta Dental PPO. There's a lot of different types of insurance out there,
Mhm.
and not all of them have been cutting fees. Some of them have been raising fees and increasing benefits.
I see. So you said you accept HMO. So how is HMO work in your area?
Well, it used to be more, but I mean, I have some.
Mhm.
Basically, the way it works is a patient picks your office,
Mhm.
and the insurance company, puts that patient on your roster, and then you get what's called a capitation payment every month,
Mhm.
$2 to $10 a month, depending
Mhm.
on if it's an individual or a family.
Yeah.
And then with that money, you have to follow a fee schedule. And normally the fee schedule includes like free cleanings, free exams, free x-rays, maybe amalgams and simple extractions are free. And then there's a reduced fee schedule for the rest of the work that the patient has to pay. It's like a discounted fee schedule.
Does that work for your
Yeah,
office?
because I think it's all the same. it brings people into the office.
Okay.
So,
I see.
I mean, on those particular plans, I make less than on, say, some of the better plans or the cash patients, but it's enough that it works for me and it brings people in.
I see. I agree. I got it. And so we have about a few minutes. So Stephen, I want to thank you for everything you have done for the community of dentistry. I mean, your contribution in many media, social media for dentists is wonderful. Young dentists learn a lot from you, and how you share your experience, the true real life experience. What else can you help young graduate? What are the thing that your advice for the young graduate dentist? What should he or she should learn to compact this 21st century dentistry?
Well, first of all, don't be so fussy about your first job. That's another thing that annoys me. I read on these groups how all these questions that an associate should ask the office where they're going to work. Just work. I mean, if the job isn't ideal, try to find a better position. But while you're working, you're earning money and you're learning something, and you work towards eventually owning your own practice. But a young dentist has to work.
Okay.
So don't be so fussy. Are they going to give me paid CE? Do I get what's my guarantee? How many days off are they giving me? When you're a young dentist, you have to work. I worked in a Medicaid office in Harlem. I couldn't get a job on Park Avenue, so I took the office in Harlem. That job in Harlem made me the dentist who I am today. If I had worked on Park Avenue, I might have been actually a worse dentist.
Right.
So don't be so fussy about where you work.
I agree. So basically, young dentists work, get experience, and that's how you learn, right?
That's how you learn what you develop speed. You learn what you're good at, what you're not good at, what you like doing, what you're not what you don't like doing, what type of practice you may want to purchase or have in the future.
Yeah, I see what your point, because sometimes if they receive a good compensation packet at the beginning of their career, and they think that is wonderful, and that's really like an ideal way of practicing, but they may not learn something that they could have learned from the place where they don't have those benefits, but they might learn.
Right.
They may able to do more things than what the nice packet of compensation, right?
Right. Well, the main thing is that the practice that they're going to work has patients for them. If the office isn't busy, then you have to maybe go someplace else.
Absolutely. Steve, thank you so much for your sharing 40 minutes with me. I'm honored and really appreciate. I hope you come back for another edition sometime down the road.
Okay.
And thank you for your time.
Yeah, no problem. Okay, good night.
Have a good one. Take care.
Okay, you too.